Conjunctiva, as you all know, is the mucous membrane that is covering the orbital part as well as the innermost layer of the lid. So basically, it is a protective layer that is giving off protection to the eyelids on the inner surface as well as to the orbital portions. For example, the cornea, the sclera, they are protected superiorly by this mucous membrane. Then we are using another terminology which is known as the conjunctival sac. This is basically a potential space between the bulbar part of the conjunctiva as well as the orbital part of the conjunctiva. So this potential space is continuously bathed into the lacrimal fluid, which is in return secreted by the lacrimal sac or the lacrimal gland that is located laterally. Now, this fluid is again providing the protective functions to the eyelid or to the eyeball, and it again has its own protective features in itself. We over here just are focusing the discussion towards the inflammatory or towards the infectious states of the conjunctiva, and primarily even these infectious states can arise due to a lot of conditions. For example, a lot of viruses can manifest as the conjunctivitis. A lot of bacteria can cause conjunctivitis. Chlamydial infections are also very notorious for producing inflammatory conditions of the conjunctiva. But over here, we are just focusing or we are just recruiting our discussion towards the bacterial causes of the conjunctivitis and how the different sorts of bacteria, which can be the community-acquired bacteria as well as the nosocomial, that is basically the hospital-acquired bacteria, can even manifest as the bacterial conjunctivitis in these patients. First of all, when we'll be discussing the conjunctivitis or the inflammatory or the infectious states of the conjunctiva, we must know the applied anatomy that is related to the conjunctiva. So what are the different glands that are responsible for the mucin that is secreted for the conjunctiva, and that is secreted obviously for the protective purposes of the conjunctiva. So over here, just to give you an overview briefly regarding the conjunctiva and regarding the different applied anatomy that we'll be discussing on and off in the lecture, I'll just give you an overview regarding that. So one should know that we have a lacrimal gland that is situated just over here, that is situated most superiorly. If we have a cut section or if we have a cross section and we are detailing the details that are regarding to this cross section, we'd know that we have this lacrimal gland over here. If we are looking from the most anteriorly towards a person, we just focus on the fact that this lacrimal gland is located laterally. It has a palpebral part and then it has an orbital part. So it has basically these two lobes that are present most laterally on the eyeball or on the eyelid. This lacrimal gland is responsible for the production of the tears, and these tears are then poured on into this conjunctival sac that I was talking about. Conjunctival sac, as I've already defined, it's a potential space between the palpebral part of the conjunctiva and the bulbar part of the conjunctiva. This portion is known as the palpebral part of the conjunctiva. And why is it known as the palpebral part? It's basically covering the innermost layer of the eyelids, and that is why it is known as the palpebral part. Palpebral is a word indicating towards the lids, towards the eyelids. In a layman terminology, we use the word eyelids, while when we talk about in the terms of the scientific terminology, we say it's the palpebral. So palpebral part of the conjunctiva, and then we have the bulbar part of the conjunctiva that becomes continuous with the epithelium of the cornea just on the limbus. Limbus is this portion where the bulbar part of the conjunctiva becomes continuous with the epithelium of the cornea. So this is the limbus. It is the meeting point of these two epithelia. So all of these terminologies you have to keep in mind just to have an overview, or just to, whenever I will refer to the terms of conjunctival sac, you should know that this is the potential space that I'm talking about. And it is spaced by the tear film that is produced in return by the lacrimal gland. So this is what we are talking about over here. Then we have the glands of Cross that are in approximate relation to the lacrimal gland. We have two groups of glands in the conjunctiva. One is the accessory group of glands, and on the other hand, we have the mucin secreting glands. The accessory group of glands consists of this glands of Cross that we are looking out over here. And then we have the glands of Wolfram. And on the other hand, we have the mucin secreting glands. The mucin secreting glands are basically the goblet cells. Then we have the glands of Zeiss. Then we have the glands of Moll, and they're basically the mucin secreting glands. So they have their own functions. Why is this mucin secreted? It's again secreted just because at the palpebral fissure, they're going to form a mucinous layer, which is again going to perform its protective functions over here. We're going to use this another term which is known as the superior fornix, and on the other hand we have the inferior fornix. These are the limitations of the conjunctival sac. The most uppermost, it is the uppermost limitation. This is the superior fornix, and on the innermost side we have the inferior fornix over here. Then finally we have the glands of Mans that are situated on the bulbar part of the conjunctiva. We have the bulbar conjunctiva situated over here. Then we have the glands of Wolfram. They're again basically a part of the accessory group of glands over here. We have the meibomian glands that are again one of the glands that are responsible for the mucin secretion at the conjunctiva. Then finally we have the glands of Zeiss. And then we have the glands of Moll, which are in close relation to the eyelashes. So these are the important structures that we have to keep in mind, the important group of glands that are present at the conjunctiva and that are responsible for the production of the mucin, that are responsible for the production of the tear film in the conjunctival sac, and all of this mucin secreting or this tear secreting characteristics are basically responsible for the protective functions that are a part of the very important functions produced by the conjunctiva, which is basically a mucous membrane covering the eyelids, and it's also covering the eyeball. Then we have the tarsal conjunctiva. So we will be using these different terminologies, that is the marginal conjunctiva, tarsal conjunctiva, we have the bulbar conjunctiva. All of these terminologies will be used. So they have their own functions. They have their own glands that are present over there, and then their epithelia is also different. If it's the marginal conjunctiva, we'd be experiencing a different epithelia over there. If it's the tarsal conjunctiva, it's going to have a different epithelium. And if it's the bulbar conjunctiva, there is going to be a different layer of epithelium over there. So we have the inferior fornix, which I've already mentioned. And then we have the glands of Cross that are located just in proximal relation to the superior fornix and then the inferior fornix. Then moving on, just if you have a cut section of the conjunctiva and you're looking at the cut section under the microscope, what would be the histological features that are relating to this conjunctiva? We'll just be quickly going through that. First of all, we have the epithelium of the conjunctiva. So just having a look at the epithelia, one should know that there are goblet cells that are situated in the epithelium. Then it's a non-keratinized kind of an epithelium that you have to remember. And then there are these 2 to 5 layers of this flat or the cuboidal cells, or even they can be these cylindrical cells that are present over here. So first of all, there is this epithelium, and then we have the adenoid layer. The adenoid layer is responsible for having the lymphoid tissue that has its own protective functions. So whenever the conjunctiva is going to be suffering from inflammation or from some infectious states, this adenoid layer comes into play, and the lymphoid tissue, it's basically providing the protective functions over here. And then we have the fibrous layer. So these are the 3 important layers that we come across upon the microscopy of the conjunctiva. Naming the epithelium, we have the adenoid layer, and then finally we have the fibrous layer, which has the elastic tissue and is also containing the blood vessels. So it's responsible for supplying the arteries and the venules to the conjunctiva, and the adenoid layer has the lymphoid tissue, which is providing the protective functions towards the conjunctiva. And epithelium, of course, it's again going to be different at the different locations of the conjunctiva, whether it is the tarsal conjunctiva or whether it's the marginal conjunctiva or the bulbar conjunctiva. So depending upon the location of the conjunctiva, the epithelium is going to be slightly differentiated, and the number of layers are going to be slightly differentiated, ranging between 2 to 5 layered epithelium, which is non-keratinized in nature. So these are the particular features of the conjunctiva that we see upon the microscopy. Then moving on, we have the epithelial cell arrangement in the conjunctiva. So if we have a look at the superior fornix, it's basically a 3-layered conjunctiva over here at the superior fornix. It's going to have the slightly cylindrically placed cells, and then on the bottom we have the most cuboidal cells that are located in the superior fornix. The number of layers is almost a 3-layered epithelium that is located at the superior fornix. And then moving on, we have the bulbar conjunctiva, which is again almost a 3-layered conjunctiva ranging from the cylindrical cells, and on the bottom we have the cuboidal layer of the cells. Then we have the upper tarsal conjunctiva. So the tarsal word is basically relating to the lids. It's relating to the superior tarsal, and then we have the inferior tarsal. So we'll have an upper tarsal conjunctiva, and then we'll be having a lower tarsal conjunctiva over here. It's almost a 2-layered conjunctiva having a cuboidal shaped layer, and then we have a cylindrical shaped layer over here. And then we have a limbal conjunctiva, which is a multi-layered epithelium that is located over here, having the multiple cells and having the locations of the different glands that are located over here. And then finally, we have a marginal conjunctiva. Just if you focus on this limbal conjunctiva, and on the other hand, at the marginal conjunctiva, you'd notice that there is almost a layer which is constituting almost a 2 to 5 layered layer that is present over here. So it's a multi-layer formation of the epithelium that is present at the limbus, and that is also present at the margins of the conjunctiva. And then finally, we have a corneal epithelium. So usually, this limbal conjunctiva, it becomes continuous with the epithelium of the cornea over here. So it's a continuation, and there is no breakup between these two epithelia. And then finally, we have a lower tarsal conjunctiva, which is quite similar to the upper tarsal conjunctiva over here. Moving on to the blood supply of the conjunctiva. So it's again very important. We have the ciliary arteries. We have the arterial arcade that is present over here. Just focusing on the fact, we have a posterior conjunctival artery that is entering, and then we have the anterior ciliary artery over here, which is a branching artery from the previous artery. It's a continuation of the previous artery. We have the peripheral arcade that is formed, and then we have a circulus major that is present just at the limbus and is also responsible for supplying the epithelium of the cornea. Then we have a descending branch and we have a circulus minor. We have an ascending branch to this artery as well. So it's basically the formation of this arcade that is responsible for the blood supply to the conjunctiva. Whenever there will be an infectious state or an inflammatory condition, this blood supply would come into play, and it would be responsible for transporting the inflammatory cells to this particular location. So this complex kind of a blood supply is very important for the purposes of the blood supply, or for the transporting the oxygenated blood to this conjunctiva. The marginal arcade is again very important over here, and then we have a subconjunctival plexus that comes into play. Moving on to the infectious or to the inflammatory conditions that occur in the conjunctiva. So what is conjunctivitis? How do you define this condition is very important. It's basically an inflammatory conditions which can arise due to multiple causes, ranging from the bacteria, the viruses, the chlamydial infections, the genitourinary infections that can manifest as conjunctivitis in a lot of patients. So this infective conjunctivitis is again going to present as the one of the main leading causes for a red eye. So the differential diagnosis of the red eye would include this infective conjunctivitis, which can have these different cicatricial causes, as well as the nosocomial causes can contribute towards the development of this infective conjunctivitis. The sign and symptoms, or the clinical picture that would be depicted in a patient of conjunctivitis, the patient would usually come up to you and would complain of the mucopurulent discharge that is coming out of the eyeball. And then also there would be an inflammatory condition, there would be the redness of the conjunctiva. Again, there are the different terminologies that are used for this conjunctivitis, ranging from the fiery eye appearance that is quite visible over here, even in this picture. So we have the protective mechanisms of conjunctiva. We know that the conjunctiva is basically protected by the low temperature, the protection by the lids. We have the flushing action of the tears, and we have the antibacterial activity of the lysosomes. And then finally, we have the humoral protection by the antibodies. So these are the natural protective mechanisms by which this conjunctiva is protected from the external environment, or by the attacks from the viruses or the bacteria. But still, even if there is a slight variation in this temperature changes, or there are some problems with the eyelids, or there's an infectious condition related to the eyelids, for example, blepharitis, it can result in the local inflammatory conditions of the conjunctiva as well. If there is some sort of a condition in which there is a hindrance of the tear film formation, even then the conjunctiva is at the stake of the infectious conditions that can arise over here. The bacterial conjunctivitis, a typical picture would be the sticky appearance of the eyes and the mucopurulent discharge, which is quite evident at the canthuses. So we have a medial canthus over here, and then laterally we have a lateral canthus that is situated most laterally. The margins of the lids would be covered with this mucopurulent discharge, and even the patient would complain of the stickiness of the eyelids early in the morning after he or she wakes up. So this would be the condition of the bacterial conjunctivitis that the patient would be suffering from. The etiology or the causative factors that are responsible for the development of this bacterial conjunctivitis include the flies, which can act as vectors of transmission from an infectious material towards the eye of the individual. Then we can have the poor hygienic conditions that are responsible for the development of this infectious state. The hot, dry climate is sometimes responsible. We have the poor sanitation or the poor hygiene that is followed by the person, the dirty habits. So all of these can manifest as the causative factors for the development of bacterial conjunctivitis in a person. The causative organisms or the bacteria that can be responsible for the development of bacterial conjunctivitis include the Neisseria gonorrhea. We have Neisseria meningitis as well. And then finally, we have the Staph aureus, the Staph epidermidis over here. We have the Staphylococcus pneumoniae, the Staphylococcus pyogenes, and the Staphylococcus pseudomonas that is sometimes responsible in a lot of cases. We have the Clostridium diphtheria. And then finally, we have the H. influenzae and the M. lecunata over here. So just by having a look at these different causative organisms that are responsible for the development of the bacterial conjunctivitis in these patients, we know that we can perform the culture and then start treating the patient in this case. But in a lot of cases, this is not possible clinically. So what we do is we give a broad spectrum antibiotic, which is belonging to the third generation of the cephalosporins, and sometimes it can cover all of these organisms that are listed over here. Then we have the mode of infection. The mode of infection would consist of the flies. So flies, they play a very important role as a vector to transmit the infection from a person who's already infected towards a person who's not infected. The exogenous infectious spread, it is known as. The flies, and we have the other infectious materials. It can be the towels that the person is using or any other personal items that the person is using and who is already infected by this kind of a bacterial conjunctivitis. They can be responsible for the exogenous spread of infection. Then we can have the local spread, which is basically from the infected lacrimal sac, or it can be from the nasal cavity or from the cranial cavity, or even the skin infections can be transmitted as a local spread to cause this kind of a bacterial conjunctivitis. Then obviously we have an endogenous infectious spread from the other systems of the body. For example, the genitourinary system. Sometimes urethritis and all of these conditions can manifest secondarily as the bacterial conjunctivitis in these patients who are suffering from Neisseria gonorrhea. The pathological states would include a vascular response. Now, whenever we say a vascular response, it means that the blood supply to the conjunctiva would be increased in these cases. And then there would be a vasodilatation response. The cellular infiltrates would be present at the conjunctival sac. And then we'd had a cellular response. We'd have all of those inflammatory cells that are present at the site of inflammation. And then we would be having the conjunctival tissue response. That is the redness and the hyperemia that is observed at the conjunctiva. That would be quite evident over here. And then finally, we'd be having the conjunctival discharge. That is mainly the mucopurulent discharge that is present at the palpebral fissure. It can be including the lower margin of the eyelid, or even it can be present at the upper margin of the eyelid. So this sticky discharge, this mucopurulent discharge that is present at the medial canthus, or it is present at the lateral canthus, that is quite suggestive of the bacterial conjunctivitis rather than the viral conjunctivitis in these patients. The clinical types, whenever we usually come across a patient of conjunctivitis, you would know that there is an acute bacterial conjunctivitis. Then the patients may be suffering from the chronic bacterial conjunctivitis. Then we have an hyperacute bacterial conjunctivitis. And then there is another form which is known as the angular bacterial conjunctivitis. So we'd be briefly going through these different clinical syndromes of bacterial conjunctivitis. Discussing the acute bacterial conjunctivitis, you should know that it's basically the most commonest cause of the bacterial conjunctivitis. So it usually takes 2 to 3 weeks to fully develop if it's untreated. And it can be complicated. It can be the cause of a lot of complications if it's left untreated. The different organisms that are responsible for the development of this acute bacterial conjunctivitis are the Staphylococcus aureus, then we have the Streptococcus epidermidis, then we have the Streptococcus pyogenes, chlamydia. All of these are the causative organisms that can cause this acute kind of bacterial conjunctivitis in a lot of patients. Staphylococcus aureus is one of the leading cause over here because it is the most prevalent organism that is present on our skin. So it is sometimes one of the leading causes over here. Then we have the Koch-Weeks bacillus, then we can have the Streptococcus pneumonia, and the normal Streptococcus epidermidis or the Streptococcus pyogenes is sometimes responsible for the development of this kind of conjunctivitis. The symptoms would include a discomfort, a foreign body sensation, and the redness in the eyes. There would be the colored halos and the blurring of the vision also observed by the individual. And then we'd be having the mucopurulent discharge. This was the main feature for the bacterial kind of a conjunctivitis, the presence of this mucopurulent discharge that is present at the limbus, at the canthi, and that is basically the most important evidence for the presence of the bacterial conjunctivitis. Then the patient would also complain of mild photophobia. Photophobia is basically discomfort when the patient comes into light. So usually the treatment would also encompass that the patient uses sunglasses, and the stickiness of the lid margins is one of the features that the patient would complain of. Especially when he wakes up in the morning, he'd complain of the stickiness of both the upper and the lower eyelids. The signs would include the flakes of the mucopus that are seen at the fornices, and then we'd have that the patient would be suffering from chemosis, that is basically the redness of the conjunctiva, the hyperemia that is noted down, and the papilla of a very fine type would also be noted down over here. Then if we can evert the upper eyelid or if we can evert the lower eyelid, the patient can suffer from petechial hemorrhages over here. Even the patient can suffer from cilia that are matted together, or there can be the edematous eyelids that are present. Then the conjunctival congestion is sometimes also seen in these patients. The complications would include a superficial punctate epitheliopathies that are present. We'd be seeing the marginal corneal ulcers, that is the keratosis, or the blepharitis. The eyelids can be involved, or there can be an inflammation of the eyelids, or even this patient can suffer from the inflammation of the nasolacrimal duct, which is known as the dacrocystitis in these patients. So if it is left untreated, all of these complicated conditions can arise in the patient. The diagnosis would be based upon obviously the signs and symptomatologies that are noted down in this patient, and obviously if we can further investigate the patient and under the microscope we can look for the cellular infiltrates that are present over there. The treatment would consist of the topical antibiotics that are usually prescribed for these patients, the irrigation of the conjunctival sac, and the dark goggles are used for these patients just because of the fact, as I've already mentioned, the patient suffers from photophobia. There is an irrigation of the conjunctival sac because we want to remove any cellular debris that is present over there, and all of the infectious material that is present at the location of the infectious conjunctiva. The antibiotics that we usually refer to in these conditions are the tobramycin, and we can also use gentamicin in these cases. But if we can even use the broad spectrum antibiotics if the patient is unresponsive to this tobramycin or gentamicin. In these cases, we can use the third generation cephalosporins for them. We can use ofloxacin and ciprofloxacin drops, and usually they are prescribed at a 7-hour duration. It's a single drop in both of the eyes prophylactically. If it's even a unilateral condition, we'd ask the patient to use the drops bilaterally, prophylactically for the other eye, which is normal at this state. And then no bandages are applied, because the bandages would give basically a humid environment and there can be a proliferation of the bacteria. So we'd avoid the bandages in such conditions. And then no steroids, because even this, the use of the steroids can flare up the infectious condition. The anti-inflammatory and the analgesic drugs are sometimes used for these patients. For example, it can be ibuprofen or paracetamol that is sometimes prescribed for these patients. The other forms of the hyperacute bacterial conjunctivitis would include we have these two forms, which is known as the ophthalmia neonatarum in the newborn, and then we have the adult purulent kind of conjunctivitis. Now, this kind of hyperacute bacterial conjunctivitis, which is sometimes very severe and very debilitating for the patient, it has a very hyperacute kind of a clinical course. It's related to the sexually transmitted diseases. For example, the patient may be suffering from Neisseria, gonorrhea, and the patient should be screened for the other sexually transmitted diseases as well. We have the gonococcal conjunctivitis, and the gonococcal conjunctivitis has its symptoms that are ranging from the moderate to severe pain in these patients. The patient would have a purulent discharge over here, and even there would be the swelling of the eyelids that are noted down in the patient. The course of the symptoms would be quite hyperacute in these cases, and if they are left untreated, the conditions can be quite complicated and quite debilitating for the patient. The signs that we would be looking for in this patient of gonococcal conjunctivitis: the eyelids would be tense and swollen. There would be marked tenderness noted down, and then there would be a thick purulent discharge that is noted down at the lower eyelid especially. There would be marked chemosis and the papillae would be formed. There would be the pre-auricular lymph nodes that are also inflamed. We'd be also palpating the submandibular and also the submental lymph nodes over here, because in some of the conditions they can also be inflamed in cases of the gonococcal conjunctivitis. Then there would be the corneal involvement that can occur quite frequently in these cases. If they are left untreated, there can be the cases of the iridocyclitis, which are not quite common. Then the systemic complications, for example, the endocarditis and arthritis, can even comply in the states of the gonococcal infections. The treatment would consist of quinolones. So quinolones is the first line of therapy over here. Ofloxacin is given almost 1.2 grams orally, QID, for 5 days. We can also imply the third generation cephalosporins over here, namely the cefoxitim, which is 1 gram administered. Then we can also imply to streptomycin over here, that is 2 grams IM for 3 days. So these are the different modes of treatment that we can imply. We can imply an oral treatment or an IV or an IM treatment in these patients of gonococcal conjunctivitis. The topical antibiotic therapy would include the ofloxacin, the ciprofloxacin, and the tobramycin. And we can also use for irrigation the sterile saline in these patients. The other general measures that can be used in these patients consists of the similar type of treatment that we mentioned for the acute kind of conjunctivitis. We can also give the topical atropine, that is 1% eye drops, basically to protect the cornea from the corneal ulcerations in these patients. Then finally, we have the chronic kinds of the bacterial conjunctivitis. We have a chronic exposure to dust and smokes, etc., that can be responsible for this chronic kind of conjunctivitis. Insomnia and metabolic disorders can be one of the leading causes over here. Local causes of irritation, for example, trichiasis. Trichiasis is basically the condition of the eyelashes which are inverted and they are continuously just acting as a foreign body for the individual. That is known as the trichiasis in these individuals. The eye strain is basically consisting of the phorias and the refractive errors, and they can be one of the leading causes for the development of the chronic conjunctivitis in these patients. The causative organisms over here are the Proteus mirabilis, we have the Klebsiella pneumoniae, we have the Staphylococcus aureus, and then finally we have the Moraxella lacunata over here. So these are namely the bacteria that are responsible for the production of the chronic kind of conjunctivitis. The symptoms would include primarily the burning and the grittiness in the eyes. There would be the mild chronic redness observed, the mild mucoidal discharge that is present at the canthi and at the lower eyelids, the watering off of the eyes, and the patient would complain of the tiredness of the eyes as well. There would be difficulty in keeping the eyes open due to photophobia and multiple reasons, of course. The signs would include of course, the congestion of the posterior conjunctival vessels, and then finally, we'd be having the lid margins that may be congested due to the presence of the mucopurulent discharge. We'd be facing the mild papillary hypertrophy of palpebral conjunctiva. So this is again whenever the eyelids are involved due to the conjunctiva, that is the palpebral part of the conjunctiva. And then finally, the patient would have a sticky look of the surface of the conjunctiva. So these are the typical clinical pictures that we would see in the chronic kind of the conjunctivitis. The treatment would include the elimination of the predisposing factors. And then obviously the topical antibiotics, for example, the chloramphenicol is prescribed for the patients. We'd be also prescribing the astringent kind of eye drops for the patients. The etiology in this case would include the predisposing factors. As for the simple chronic conjunctivitis, the causative organisms would be the Moraxella axonfield for this angular kind of conjunctivitis. And then finally, we have the sources of infection, for example, from the nasal cavity. So the local transfer is very important in this angular kind of conjunctivitis. Then we can have the modes of infections, which is basically the contaminated fingers and the handkerchiefs. So basically, whenever we have this angular kind of conjunctivitis that the patient is suffering, we'd be looking at the medial canthus and especially at the lateral canthus. Sometimes they are inflamed, they are hyperemic, and even the skin is macerated in these cases of the angular kind of conjunctivitis, and the causative factors and the causative agents are already listed over here. The pathology would include the proteolytic enzyme synthesis by this Moraxella axonfield bacillus, the collection at the angles by the action of the tears, and that basically gives way to the maceration of the epithelium of the conjunctiva. The lid margins are even macerated in these cases, and even the skin is involved in these cases. Then we have the vascular and the cellular responses. There would be a mild grade chronic inflammation that is observed in these cases, and the skin may show even the eczematous changes due to the continuous irritation. The symptoms would include a mild irritation and burning sensation and discomfort that is observed. There would be a history of dirty white foamy discharge, especially observed at the angles, that is the medial and the lateral canthi, and the redness in the angles of the eyes, and especially in a lot of cases, the skin would be seen macerated. The signs would include the hyperemia of the lid margin, the hyperemia of the bulbar conjunctiva, the excoriation of the skin around the angles, and then finally the foamy mucopurulent discharge at the angles. If it is left untreated, what are the typical complications that can arise in this patient? That would encompass the blepharitis, that is basically involving the lower lid or the upper lid, the marginal cataract, corneal ulcerations. The treatment would consist of prophylactic treatment, and that would consist of a good personal hygiene and treating the nasal infections appropriately and promptly. Then finally, the curative treatment, which would consist of the oxtetracycline, that is almost 1% eye ointment, and zinc lotion that is usually used in the daytime. So over here in this lecture, we briefly summarized the bacterial conjunctivitis. So according to the clinical course, this kind of bacterial conjunctivitis can be subdivided into the acute kind, we have the hyperacute kind, we have the chronic kind, and then finally we have the angular conjunctivitis. How to deal with these conjunctivitis and what are the management plans that can be plotted out for these conjunctivitis cases that are summarized over here. So thank you for watching sqadia.com.